Okay, good afternoon, everybody. We're just gonna take a few minutes to let everybody log on and get settled, get their audio working and everything. And then we will get started. I'm just seeing lots of people drop in from our waiting room here, so we'll give everybody a chance to get settled. Okay, I see lots of new people joining in. Happy to see everybody here today. Thank you for joining us. My name is Rennie, and I'm a counselor at AGI, or Alzheimer Group. If you're joining us for the first time, at AGI, we support people who are living with dementia and those who support them through programming for people living with dementia, counseling and support groups for caregivers, and education, like today's lecture. And today's lecture is being made possible by the generous support of the Lindsay Memorial Foundation. I just want to note a few housekeeping items before we begin. We ask that you please keep yourself on mute. But if you have any questions for our presenters today, please write them in the Q&A box that you should see along the bottom of your screen, and we'll make sure to address your questions at some point or at the end of the lecture, so don't worry. Today's lecture, which is all about the challenges of accessing palliative care for caregivers of individuals with dementia, is part 2 of a 2-part lecture series on end-of-life care in Quebec. So welcome back if you were here with us for part 1, and you are also more than welcome to be here if you're only joining us for the first time today. Just so you know, you'll be getting sent a copy of the slide deck as well as a recording of today's lecture after it's over. So without further ado, I just want to introduce our speakers. We are joined here today, first of all, by Zelda Freitas. Zelda is a social worker and the coordinator of the area of expertise in caregiving at Caregivers, which is the Center for Research and Expertise in Social Gerontology. She has extensive experience in the provision of psychosocial care to adults in loss of autonomy. She is a member of the Council on Palliative Care since 1998, offering educational presentations on topics related to caregiving issues, grief and loss, and access to care. And Zelda has recently been named as an adjunct professor at the McGill University School of Social Work. We are also going to be joined today by Patrick Durivage, who's on his way to us right now. And since 1999, Patrick has been interested in the elderly population receiving palliative care. For many years, he was an accredited regional trainer and runs trainings for professionals on clinical tools related to loss of autonomy. He has contributed to the creation of various trainings and manuals on palliative care. He's part of the McGill Council on Palliative Care, a not-for-profit organization that educates the general public about palliative care. In 2015, Patrick was appointed at the Quebec End-of-Life Commission. I'm now going to hand it over to you, Zelda, and Patrick, when he's able to join us. We are all looking forward to learning from you today.
Well, thank you very much, Rennie, and thank you everyone for being here with us today. As you know, this is the second part of a 2-part series, so we're going to cover today the rest of the law, rest of the part 2 law. Sorry, I'm getting all mixed up already. The rest of Law 2, which covers medical aid in dying and palliative sedation. So I'm hoping that Patrick's going to join us soon. He's having a little bit of technical difficulties, but he will be with us shortly and he'll pick up the presentation with me once he arrives. So I'll just get us started. So what we covered last week, we covered the introduction to Law 2. We covered the presentation on the 4 different elements of the Act respecting end-of-life care. We covered part 1, which was advanced medical directives. We talked about access to palliative care and what palliative care is in terms of the law. And we had some question and answer period. And we had a wonderful time and a wonderful conversation with all of you, or those of you that were here with us last time. So today we're going to cover continuous palliative sedation, as I mentioned, and medical aid in dying. And we're going to leave some time for questions, of course, at the end. And we welcome all your questions. If you have questions along the presentation, you could put them in the chat. Maybe Rennie can let us know what those questions are. She could maybe regroup them for us. And if there's anything about the presentation that you want us to address immediately, again, I look to Rennie to let us know that, because we can't see you on our screen. If you put up your hand, I'm sure she'll be able to address what you might need answered right away. So I could see now that here Patrick is with us, and we're happy to have him here in the room with us. So he made it. So without further ado, we'll continue on, but I'll let him say hello and introduce himself.
Hi, everybody. Sorry for the delay. Virtual traffic, I guess. My difficulty connecting with my Wi-Fi. So my apologies for being late. Thanks, Zelda, for filling in and starting the presentation. So yes, we'll have some time for a question and answer at the end. We're going to go to a section, of course, medical and dying. It doesn't apply necessarily for people with advanced dementia, but for people with maybe the beginning stage of the disease, it may apply. So we'll try to make it relevant for you who are wondering why we're presenting medical and dying for that part of the presentation.
And so just to let you know, Patrick, that I have the PowerPoint uploaded, so I'll be changing the slides. So I'll try to follow along with you, but just let me know if you need me to change. Just say next slide. Okay.
Perfect.
So now we're going to go to the next slide. Go ahead.
Palliative care sedation. Well, continuous palliative care sedation, it's part of the Law 2. It has been in place for many years in Quebec before Law 2, but this time it's been part of the palliative care continuum. So what it involves, it's putting somebody in a kind of an artificial coma because the pain and suffering is too hard. It cannot be relieved by other means of by medication or other type of treatment. So palliative care sedation is offered really at the end of life. Usually there's a prognosis of 2 weeks and less. So, and the other treatment has failed to respond to the pain and suffering of the person. So the person can request palliative care sedation, or a family member could request it also on their behalf. And it's a process that's been a bit more talked about. There's been as much of palliative care sedation as medical and dying in Quebec for the last few years. So it's an approach that helps the patient to be relieved from their suffering by keeping him or her unconscious throughout the process until the natural death occurs. So it's a process that involves just having probably a pump on the bedside to inject some medication on a continuous basis. It could be done at the hospital setting, but it could also be done at home. So it's something to consider and to explore. There's definitely some nursing to be involved to make sure the patient's still comfortable and still relieved from the pain. And it's now it's why it's part of Law 2, because the health ministry want to monitor how many has been done per region in Quebec, so to see if the offer of the palliative care sedation is accessible throughout Quebec. So that's pretty much what we can tell about palliative care sedation today. Move to the next slide. So where to get information? Well, there are some explanation in the rights of the person at the end of life, the flyer that we show you the first section, and there's also a section on quebec.ca where there's some nice description of all the palliative care options that we're explained today in a simple, direct way. So there's a little section on palliative care sedation. So it's something that very often it's healthcare workers that will offer that care at the end of life. It's pretty rare that family members will request it because they don't know about it. So usually it's more the medical team that will have the lead and say, well, we tried everything to relieve the pain and suffering of your loved one, and maybe the person is also very agitated or has a lot of nausea or a lot of other type of symptoms that cannot be relieved by the traditional way, and they may offer palliative sedation at the end to relieve the symptoms that they have. So that's pretty much Zelda. So medical and dying. This aspect is pretty well. It's the definition of medical undying. It's pretty self-evident. It's basically administration of three type of medication by physician to relieve the patient's suffering and by hastening death. So basically, after the administration of those two drugs, the patient will die from those administration. So one of the medication is kind of a relaxant to put some person in a sedation mode. The other one is to stop the lungs, and the third one is to stop the heart from beating. So after those three injections, a series of injections, a patient dies, and it takes usually about 10-15 minutes and that the process is done peacefully in all care settings. It could be done at home, in a hospital setting, in nursing home, and in some palliative care hospice or unit. So it's accessible throughout Quebec since 2015. Next slide.
So medical aid in dying, this is a criteria that is presently in effect with regards to medical aid in dying. So the person has to meet all of the following criteria in order to obtain medical aid in dying. They have to be insured under the RAMQ. So they have to be insured by our Medical Health Insurance Act. So they have to have a RAMQ card. They have to be over the age of 18 and capable of giving consent to care. So they have to be considered able to give consent, meaning they have to be apt. They have to be at end of life. They have to suffer from a serious and incurable illness. This is all stated in the law. They have to be in an advanced state of irreversible decline in capability, so irreversible and in continuous loss of autonomy. They have to be experiencing constant and unbearable physical or psychological suffering. So this is where the suffering aspect of it comes in. That cannot be relieved in any manner that the person themselves deems tolerable. So it has to be something that's defined by the person themselves in terms of their ability to tolerate the suffering that they're experiencing. And this is a definition. This is the criteria that is in application at this point in time.
So
ahead,
those criteria, if you just want to go back just a second.
Sure.
There's a little star for be at end of life since the Truchon and Gladu judgment. This is is not in operation in Quebec, so that has been removed from the criteria, but that was part of it for since 2015 up till 2020. The person had to be at end of life. With the Gladu Truchon hearing, the person doesn't have to be at end of life. So the criteria has changed, and since C7, the federal law put also new criteria, which we'll look down the road of the presentation, but the person doesn't have to be end of life now.
So that's the major change that we've experienced in the last year and through the court case and etc. That has a major impact on the criteria, because it's like you said, Patrick, one aspect that no longer needs to be considered.
Yes.
Okay.
Next slide.
Go ahead.
So the physician, before administering the injection I was talking about, they have to review all the criteria, of course, and they have to make sure that the request is made out of a free will, that there's no external pressure from any family members or any other person, that the person is coming from their own request, and they have to make sure that the patient has still a prognosis that it's kind of leading to a death. So not within the parameters that we used to have, like being at the end of life, which was like 6 months to a year. So now that timetable has been a bit stretched with the new bill. There still has to be the physician has to make sure that the suffering and the person, it could be physical, emotional, spiritual, different type of suffering has to be present, and that all the different approach or treatment was offered to the patient before considering medical undying. So they have to review the chart. They have to offer the different treatment that's available, and the patient could refuse or accept treatments, and they could withdraw the request if the other treatments were successful. So that's why there's a time asked between the demand and the administration of the medical undying to give enough time to do the assessment, but also to give time for the patient to really reflect on the request, because it's irreversible. Once the injections are started, there's no coming back. Next slide. So within that process, the physician will review all the requests for the family. If the patient wants, make sure that the patient had time to reach the family members they wanted to reach, and also to communicate with the training team, either the CLC team or the hospital team, to see if they're in agreement, if the process makes sense to them. But it's really looking at the overall team approach to make sure that all the different aspect was that. So we don't want any like foreign physician that just comes in and goes and injects. No, they have to be part of that case discussion and to kind of have the consultation with different parties involved, make sure that's what led to the request, and have a closer understanding what the request was all about. After the first evaluation is done, then the physician would ask a second evaluator to be involved. So that second evaluator has to be a physician or a doctor, and that has to be independent with the first doctor, of course, who will also review all the criteria that we show, and that will also examine the person himself or herself to make sure that the request is legit and that they follow under the criteria of section 26 that we reviewed. So the second evaluation is really to make sure that the patient is on board and that everything has been, all the stones have been turned and all the different approach has been kind of tried before they go through the process of medical undying. So the second physician, they also have to write a report, and the first one also. So those reports are sent afterwards to the end of life commission. So there's a check and balance within that process. Next slide. So the procedure, it's really that the person has to request it on their own, and they have to be informed what it entails. They have to understand what's going on, what's the process, what's that procedure in place. And of course, that request, there's a special form that's been drafted by the health ministry. They have to be signed by the person and a healthcare professional and a witness. So now it takes one witness to be able to request medical undying. So that the healthcare worker could help you to fill that form with that person. And of course, the form is returned to the health establishment to assign two physicians who will do the procedure. So if you have a family doctor that wants to be part of the process, that's great. That's what we want, one continuum of care. But if you're a treating team or a family doctor doesn't provide that care, then you just the healthcare worker would send a request to the health establishment, like to the CUS. There's a committee that will assign physicians. So you don't have to shop for a physician to do the procedure. It'll be appointed by your healthcare establishment.
So every healthcare professional has a right to refuse to participate or administer medical aid in dying. And the reasons for that is that they might have personal convictions or other reasons, but mostly it's because of personal convictions. Or some establishments, for instance, if they're in the private sector, or they may decide that their establishment will not be administering medical aid in dying. So in this case, though, it doesn't mean that the person no longer has access to medical aid in dying. What it means is, and the onus is on the physician and the healthcare professionals to ensure that this person has continuity of care and that they have access to medical aid in dying if that is what they wish. So even though the physician themselves that may receive that request is not may refuse to administer that request, they have to make sure that that person who has access to that care, to that continuity of care, by linking them up with another physician that will do the evaluation and etc. So it doesn't stop with that physician. They do have access and they have to facilitate that access. All healthcare professionals have to ethically inform people of the right to medical aid in dying and the information and all the information that we're providing with you today, for you today, in terms of the procedure, the criteria, etc. we're obliged to provide the basic information to people when they ask about it, and make sure that they have access to information so that they're well informed about medical aid in dying, such as, for instance, the pamphlet that we referred to earlier on in the presentation. That would be one piece of information. The website is another piece of information that is provided to people so that they have the information that they need to make the decisions that they want and that they want to make. Patrick?
Yes. So in terms of the safeguards that were put in place with the law too, the physician that administers medical and dying, they have 10 days to send their declaration of the care that was provided to the end of life commission. So that's to ensure that all the requests are being fulfilled. Why is that? Is because, well, we want to keep a check and balance of the the procedures that were done, and that the check and balance is also done with the pharmacy at the hospital where the kits are put together. So the pharmacist will send a report, the physician will send a report to the end of life commission, and if the physician is not part of the CIS or the CIUS, they have also to send their report to the Collège des Médecins. So Collège des Médecins will keep a track of all the physicians that are part of a CIUS. So if they work in a private clinic, there's also a check and balance with that body. So if the end of life commissions that reviews the files sees that the request wasn't valid, then there's procedure that the end of life commission puts in place to inform the Collège des Médecins, and that body reviews the file and could fine doctors for providing the wrong care to the wrong patient. So far it hasn't happened in Quebec, but there's still those checks and balances to make sure that that exceptional care is only provided to people that are requesting it. Next.
So, sorry.
So the end of life commission is kind of an independent body that's appointed by the different orders. There's one pharmacist, a social worker, a few physician, ethicist that's part of that committee. There's a nurse. There's like a different expert in their fields that have been appointed by their order to review all the requests that have been done in Quebec, and also makes recommendation to the ministry about any end-of-life issues that may occur in Quebec. So it's not just for medical and dying, it's also to look at access to palliative care, looking at the different care continuum, and looking at the service provision in all region of Quebec. So the end-of-life commission, they have to do a 5-year report on the end-of-life situation in Quebec and make recommendations. And we follow up with the healthcare ministry that make sure that those recommendations are carried on. And it helps to make sure that the end-of-life care in Quebec is accessible for all citizens.
So what the bill does not address is it does not define necessarily end of life, and that leaves it up to interpretation. It ensures that medical aid in dying cannot be requested by a person that is not insured or a person that is a minor. So that's spelled out in the law. Therefore, if you're not insured by the RAMQ, and that also stops people from coming to Quebec to pursue medical aid in dying from other parts of the world, as they experience in some countries in Europe. People would go there just for that particular medical act because they were able to have access to it. So they have to have an insurance, a medical insurance card, a RAMQ card, as we say, here in Quebec. And for a minor, in the case of a minor, a parent, for instance, cannot give consent on their behalf. So it's not like, when you're a minor and you need your parent to give consent for surgery, for instance, that can be done. But for medical aid in dying, there is no provision for that, for someone to give consent on the behalf of a minor. The other important criteria that Patrick will discuss a little bit further on, because there are some changes that have occurred, but the criteria to obtain medical aid in dying excludes individuals with disabilities or those suffering from psychological disorders that are not at end of life. So this is a really key point of discussion, because we know that if you've been following any of the news with regards to this, and Patrick mentioned earlier the court case that occurred in Quebec, it's really something that's changed and that Patrick will address in the next few slides. So this is what the bill does not address, and it's important to know what that is as well. Go ahead, Patrick.
Okay, so if you look at the left side of your screen, the gray path is kind of what was put in place in Canada since 2016, in Quebec is since 2015. But for the rest of Canada since 2016, to be able to request medical undying, you need to have a serious or advanced medical situation, which was the death was kind of reasonably foreseeable. So meaning that there was a time frame that was kind of set that the physician could pronounce that you had a prognosis of less than a year, less than 6 months, and that led to your death. In order to be able to get medical undying, you had to go through the two evaluations, pretty similar to the rest of what we discussed today. And the patient had a time to reflect. They had a 10-day period to reflect on the process, and they could withdraw the request at any moment. So those were kind of the criteria that are pretty similar. And before the administration of medical undying, the patient had to be able to consent to the care. So if they lost their capacity to consent, if they became inapt in the progression of their illness, then they wouldn't qualify to get medical undying, and the procedure would stop because without the consent, the patient couldn't get it. Now with the new bill, the Bill 7, there's two different pathways that would lead to medical undying. So the criteria are pretty similar. You still have to have a condition, medical condition that's kind of advanced, incurable. You need also to have an advanced decline in your functioning. So you need to have pretty much some incapacities in your daily activities, not be able to do most of your activities on your own. And you need to still have a time frame that's kind of a set that would lead to medical undying. The first path is if you have a time frame of a year or less, you could request medical undying. And then the first set of safeguards is that the person will have to go through the two evaluations, and they could request medical undying in that time period. There is no waiting time that has been assigned. That 10-day period I mentioned, that was kind of withdrawn from the law, the federal law. And at any moment, the patient could ask for medical undying, and they could even sign a consent form with the physician that if they do become inapt, they could still get medical undying. So that was put in because a lot of patients was withholding their medication to be able to consent to care and be able to be apt and they were afraid that taking narcotics, they would be confused, or they would that would lead them for some delirium. So a lot of some of the patients that are when going through the evaluation process were kind of adding some suffering to that experience by taking less medication to be sure that they were able to consent, because they were afraid that with the narcotics there would be some confusion period and they wouldn't be able to qualify for medical undying. Now with this new pathway, as the moment that the two physicians do the evaluation and the consent form is signed, then the doctor could administer the request even though the patient loses their capacity to consent. So that's one path. The second path is for people with a longer life expectation of over a year and a half. The time frame I'm referring hasn't been defined yet in the law, but what we're seeing is that patients with a year, 2 or 3 could request medical undying. If we think about a patient with MS or multiple sclerosis, or with those neurological disease where the end of life is it's kind of long, and there's still some great incapacities that the patient has, then that could be requested. So The process has changed a bit for those patients within that path. Is they have to go through the 2 evaluation by the physician. One of the physician would have to be an expert of the disease. So if we take the example of a multiple sclerosis, it would probably have to be a neurologist, it would have to be part of the evaluation process. And the waiting time and the evaluation time is set to 90 days. So the patient would have to wait 90 days before they get the medical dying. And in that pathway, unfortunately, they're not able to withdraw their final consent. So they would have to consent to before they get to medical dying, because they're expecting their ability to consent will still be still good in that process, because their life expectation is it's longer. So that's the 2 pathways. Of course, there's always exception to the rule. If you're in the second pathway and your situation changed, then you could be put in the first pathway and get the medical dying sooner and go through the same evaluation and sign a consent for to withdraw your final consent. But that's by exception. So just to simplify, let's use the 2 pathways. One is for a person that the life expectation is less than a year, and the second one is for more than a year, and without any possibility to, of course, regain your functioning. In the Bill C7, they put aside all the patient with mental health issues that were asking for medical dying just for that reason, because they had the solely mental health illness, and that's been excluded from the C7. So there will be a committee that's going to look at that specific issue for people, or they have like either major depression or they suffer from schizophrenia, but they're still able to consent to care. Those patients will have to wait until 2023. There'll be a committee that's going to look at the criteria and maybe some additional safeguards to make sure that they're fully understanding whether they're going through that process. So that has been put aside. Same thing for people with early set dementia. They're not able to request it by anticipation. So you're not able to sign a form similar to the medical advance directives. Even though there's been a movement in Quebec and Canada for patients to be able to request it with early set dementia, that hasn't been out. There'll be another committee that's going to look at that, and that will come up in the next few years. We don't know exactly when, but I know there's a committee in Quebec that's looking into it. There's even been a report that's stated from a different expert that people with should be able to request it by anticipation, but we're not there yet. But there has been some work done, but it's still some change in the law to review it. Which brings me that all those change that I presented on the C7 applies for Canada and not for Quebec. We still have to review the Quebec law, the Law 2, to be able to integrate some of the elements of not be able to be able to request the final consent to be removed. So that's not part of Quebec's law. So people will still have to be able to be apt to request medical dying, even though they have a year or less prognosis. So the other element is still applicable, but there's some little changes that we have to make in the law in Bill 2 in Quebec to be able to fully integrate the C7 modifications. Keep in mind that just to make it very simple, when you request for medical dying, just talk to your healthcare workers to make sure that you're eligible and that there's a two level of the law applies to your situation. So I won't go too much details in terms of what belongs to the federal, what belongs to the provincial, and why it's not harmonized. But basically, your healthcare worker would help you to kind of look at where you fall and what path you fall with your request. Next slide.
So Patrick made some reference to medical aid in dying and dementia, and the fact that at this point in time, it's important to point out that it's not possible to request medical aid in dying in anticipation, meaning in advance. And I would just add to what you had said, Patrick. It made me reflect on I think one of the reasons that the federal law on medical aid in dying changed with regards to the second consent or being apt at the time that medical aid in dying was going to be applied was because there was actually quite a big case, I think, in Halifax, if I'm not mistaken, in Nova Scotia, where a woman who was suffering with advanced illness had requested medical aid in dying, and then was afraid that at the time that she was going to be scheduled to have the Medical Aid in Dying Act performed, that she would not be apt. And she needed to be apt and competent for the procedure to be administered. And her fear stopped her from taking her medication, but also she actually asked for it earlier than she had anticipated, and then wrote quite a lengthy letter regarding how unfair she felt that this was, that she wanted to have the act performed, but at the same time didn't want it earlier than necessary, but felt that she had to do that because that she was afraid that she was going not be able to be competent at the time. So they really had to reflect on that, and her case, her situation had an impact on that. So she spoke out, and I think this is what's helped move these laws along, is people speaking out and questioning and reflecting and bringing those reflections forward, so that the law could really reflect what the citizens want in place. So for now, no requests in terms of anticipation or in advance, which has had an impact, as Patrick said, on people that are suffering from dementia or dementia type illnesses, because they're not allowed or not able to ask for an advance, because here's, you still have to be able to be apt at the time that it's administered. The role of caregivers, we've been concerned, Patrick and I, since the law has been enacted, with regards to caregivers and families, and how their implication is, how they're involved in the process, how they can be a support, but how do we also support caregivers? And there's been some situations where caregivers and family members have been left out of the process completely, and that's been detrimental to them. And then we have other situations that Patrick could speak of as well, where families have been involved. And it's not to say that they will not have some emotional impact afterwards, but from research that we've read that has been done, families that have been involved feel that they feel that in some way, not privileged, but that it's important for them to support the person that they love in the decisions that they're making, and that's how they're viewing it as well. So we're expecting some updates in the law too here in Quebec in the fall of 2021. And like Patrick said, that might be ambitious, but we know that there'll be some reflection now with regards to the changes that Canada has made in their law that Quebec will now have to incorporate. So it's sort of a back and forth. As you can see, Quebec enacts the law, Canada enacts their law, Quebec's made some changes, Canada's made some changes. So it's a little bit of back and forth, but it's a healthy back and forth, I would say. So we wanted to talk a little bit about, and hopefully you'll have some questions, and we're very open to answer some questions. We really wanted to present you the law and medical aid in dying, and we know that it's a very complex thing. There's a lot of emotions around this law, and rightly so. But so if you have any questions or any reflections, we'd like to hear from you just after we finish this piece of the presentation. We wanted to show you a little bit about where does this law come into effect. Where can palliative care take place, and where can medical aid in dying take place? Well, it can take place at home. So we have a nice picture of a house at the beginning. If you live in an apartment or in a condo, so just to say it can take place in the community. It could also take place in long-term care settings, so in CHSLDs. As we see, we have a picture at the left-hand corner, or my left-hand corner, of St. Margaret's CHSLD. That's in our territory. It could also take place at the hospital. So either in a palliative care unit or in a dedicated palliative care bed or anywhere else in the hospital, actually. Mount Sinai has a palliative care unit as well, and it's important to know that it can also take place there. So basically, we're just trying to let you know that it can basically take place anywhere that the person that you're caring for or for yourself may be at the time that these services would need to take effect. There are also two palliative care residences that I think it's important to highlight that you may not be aware of. There is a St. Raphael palliative care residence, which is in Outremont, a beautiful palliative care residence. Recently, it's only been in, I think, 2 years now, I believe, Patrick.
Mhm.
If you ever get a chance and if you do want to see what a palliative care residence looks like, they accept visitors. You just have to call them in advance and they're more than welcome to have you come and visit. So it's a palliative care residence where people go when they're palliative, and the family is very, very involved and very welcome. The other picture is of the Teresa Deller Palliative Care Residence in the West Island, previously called the West Island Palliative Care Residence. And they've actually just expanded not too long ago as well. And so they're a wonderful, beautiful residence that look at the whole person care that we've been talking about when we talk about palliative care. So again, if you ever have a chance and you want to see what palliative care is all about and what that would look like, you can call them and they would welcome you to come and visit at least some of the parts of the residence that is not private to the patients, to the residents that are there.
Because of the COVID, though the visits
Yes.
are been suspended, but they could definitely show through their website. The West Island has a kind of virtual visit you could do, and the Maison Saint Raphael, they could send you some pictures of the facility in terms of give you indication of the size of the room. They most of them they have private rooms also, so it's good to know. And in terms of access is for people with an end of life situation with their expectation of 3 months and less to be able to access those resources. So there's no charge for those facilities. And San Rafael, they also have a day center where they provide some recreational activities, massage, or some symptom management or education in terms of how the situation will evolve. So there are two great resources in the community. So.
And the reason that there's no charge is because they are funded by the Health and Social Service Ministry. The beds are funded and the services, the professional services there are funded as well. So we just wanted to end with a workshop that actually Patrick and I are presently running, and we thought we'd just mention it if any of you are in a situation where you're taking care of someone with serious illness. We are offering the workshops both in English and in French. They have already started, but we're only in our second session, and we welcome new participants up till the third session. So if you are interested, let us know. It really looks at issues of advanced illness. So we touch on a lot of different subjects like accessing resources. We talk about trajectory of illnesses. We talk about caregiving in these circumstances, taking care of someone with advanced illness. So we do touch on all of the financial and practical aspects of caring for someone with serious illness. And we talk about how that impacts caregivers and caregiving, and the particularities of caring for someone with serious advanced illness as well at home. So you're more than welcome to either give Patrick or I a call, and we'd be very happy to have you join us for our third session, which would be next Tuesday in French and Wednesday in English. Go ahead, Patrick.
We invite also Nori to discuss the protective regime. We discuss advanced directives. We also discuss the planification of care, mobilizing your care team. And also there's 2 great sessions on stress relief, strategies to deal with stress, and also a session, of course, that Zelda and I are quite fond is looking at grief and losses. So there was also a session on that to help the caregiver to adapt to the multiple loss of the care receiver capacities, abilities, and personality, identity. So the fact of losing somebody down the road with the illness, but also how the illness affects that person, their rapport. So it's very based on the relational aspect of the caregiving, and not so specific on the disease, but more specific in terms of the impact of the relationship it has between a caregiver and care receiver. So it's a great workshop. So if you can't attend this time, just give us a buzz, and we'll put you on the list for the upcoming ones in the fall.
So with that, we thank you very much for your attention, and we welcome any comments and questions that either Rennie has collected, or you want to open your mic and go ahead and ask us. So I turn it over to Rennie.
So thank you so much, Zelda and Patrick, for helping us to learn and think about some very challenging and very important topics today. So we really appreciate you being here. It would be great that we can take some time now to address some of the questions that we've been getting. And I do just want to encourage all of our attendees today, if you have some burning questions that you're thinking about, there's still time to throw them into the chat or into the Q&A box, and we can try to make time for them right now. One question that I'm seeing here for you guys is someone's wondering, can palliative sedation be done at home, or does it need to be done at a hospital?
It definitely can be done at home. It's an easy setup. The CLSC would provide all the equipment in terms of the pump. They will the nurses will train the caregiver on how to monitor, and they'll give them access to a 24/7 hotline number to be able to reach a nurse if there's any issue, or if the machine starts to beep, to be able to make that experience feasible at home. So yes, we did a few so far at home, and it went well. So it's definitely possible to do it at home. It doesn't have to be in a hospital setting.
Okay, that's excellent to know. Thank you, Patrick. Another question that we have here is you've mentioned how about that physicians can refuse to provide MAID, but do need to provide information about it. And someone's wondering, if your doctor, like your GP, let's say, refuses to provide MAID, how do you go about finding someone else, another doctor who will?
Okay, so if you're attached to either a CLSC or even your doctor should be able to give you the information where to send your request. But if you're followed by the CLSC, all CLSC workers have been trained on how to proceed with the request. We all have access to the form to sign, and there's an internal procedure on how to send that request to the hospital, who will assign the two doctors. So there's no stress on the caregiver. You just have to talk to one of the healthcare workers. So if it's your family doctor doesn't want to provide it, should still be able to give you access to information on where to get the form and how to get it sent to the hospital to be able to get those two physicians. So it's their deontological obligation to provide information. If they don't want to be part of the act and the administration of the medical and dying, totally understand, but it's still their responsibility to send the referral to the proper doctor who will take care of the process.
And it goes by CIUS, right? So it goes by your CIUS territory, where you live, and not where your doctor's office is.
Mm-hmm. Mm-hmm.
Okay. So if you live in our CIUS territory, the Centre West, West Central, then it would be the Jewish General Hospital, for instance. That would be the hospital that would be responsible to ensure that they find someone, a physician to help you.
Okay.
Yeah.
Thank you for that. That's helpful to know. Another question that we're getting is in terms of people who haven't already made a request for MAID, but might be considering their options, might be considering palliative care options as well as MAID for that matter, and particularly for caregivers. Are there specialized counseling services available? I understand that, some of your courses that you've mentioned can cater to that, but, where can people find support and guidance around those kinds of considerations?
Well, the triggering factor, the factor that will lead you to palliative care services, very often a physician that will kind of give you a prognostic that your situation has evolved to a state where palliative care is required. So basically, it's either your family doctor or one of your specialists that will trigger that conversation, provide you some information in terms of how to access palliative care. In order to get counseling or some information, just general information about palliative care options, well, any of your healthcare workers could provide information. I know that we're training all the home care workers to be uh, at least equipped with the basic information of where palliative care services available in our CUs and the healthcare network. So definitely, if there's some clients that wants more information, the social worker, the nurse could definitely answer those questions in terms of accessing palliative care services. And within the home care department, we have a palliative care team also that's their job. They only do palliative care, and they could be asked as consultant to answer some questions. I was asked to be a consultant to meet some patients at home and to give them some information. Okay, what service out there, or how does it, what type of a referral that needs to be put in place to be able to access the service. So talk to your either your pivot nurse at the hospital or your family doctor, and they could send you to the right person. I think it takes more than just reading some documents online or some information. It's usually a face-to-face could help to provide information. And if there's just general information in terms of palliative care, there's also 811 info helpline that could help you with some getting to know the services that's in your area. So they'll ask your postal code and they'll tell you, well, in your region, this is the type of palliative care service that's provided. So that's another source of information.
Yeah, it's definitely a tough decision, like any other tough decisions are, right? We caregivers grapple with a lot of really complex and difficult decisions, and so having someone that you can talk to about that. So I could imagine that some of the illness specific associations, such as the AGI, provide some counseling and some help to caregivers to help make those tough decisions, or at least explore that decision making process, what pros and cons and the consequences and all of that. That's all part of counseling around illness, right? And I'm sure, for instance, like the ALS, the SLA Society would also, with their counselors available, could help caregivers explore some of these very difficult issues. But having the basic information from this session today, for instance, and from gathering up information, good, solid information, it helps caregivers and helps families make those very difficult decisions. And that's really, it's really important to have the information, but also be able to have someone that you could speak to about making and exploring these difficult decisions.
I would just like to add, in terms of for caregivers dealing with somebody with any kind of dementia, accessing palliative care is a challenge. It's easier to access palliative care when you have a cancer.
Oh, Patrick froze. Oh, there you are.
You're back.
Okay.
He's back.
I wasn't moving, maybe.
It's okay. I was going to finish your sentence.
So for
Oh, he's frozen.
You might have to, Zelda.
Yeah. He's basically saying that it's very difficult to access palliative care traditionally palliative care, or historically, I should say, palliative care has been more accessible to people that have a diagnosis of cancer, just because the illness trajectory of cancer is it more predictable than other illnesses, as those of you may know that are caring for someone who has dementia or Alzheimer's dementia. It's very difficult to predict what's going to happen tomorrow or even this afternoon, never mind what's going to happen in the next few months, right? So, but now, the law that was put in place really defines palliative care as accessible to all that have advanced illness, and an integrated palliative care approach is extremely important for all people that have a serious illness that they're grappling with, because everyone can benefit from good, solid palliative care. Which encompasses quality of life and reduced suffering, and looking at all of the issues that are difficult to look at. But palliative care opens up those issues with open arms and saying, let's look at this, let's make it the best possible life available to you and the family members. And so, yeah, so this is the push now, and is to make it more available to everyone. because no one should suffer at the end of life, and no one should watch their family member suffer. And this is what palliative care tries to address, is this issue of suffering as well.
Absolutely. Thank you for that. Another question, and we're going to wrap up soon, but just another thing that we'd like to know from you is something you mentioned earlier on, is that you do need to have RAMQ, you need to be covered by RAMQ in order to access MAID in Quebec. What about for people who might not have citizenship status yet and might be covered by something like the interim federal health plan, or maybe they've moved from another province and don't actually have that RAMQ coverage? Are there safeguards in place for people like that who do live here, who aren't, traveling for the purposes of MAID, as I think you mentioned? But wow, yeah, what are options like for people in those situations?
I hope I won't freeze when I talk.
It's okay, I'll finish you.
Okay, as long as you're covered by the Canadian federal health insurance, then you're fine. It's just that we want to avoid the tourism, medical aid dying tourism. So as long as you're covered by either federal or provincial government, you'll be okay to get that care.
So even if you have landed resident status, for instance, you have access to RAMQ, or like you mentioned, the coverage of the federal, that's also accessible because that also covers. And if you move here from another province, you are covered by your province of origin for the first 3 months, and then RAMQ takes over after that. So there is still that maintenance of coverage. So that makes you eligible for either the first 3 months from your original province of origin, or you wait the 3 months and then you're covered by RAMQ once you're in Quebec for 3 months.
Okay. Thank you. That's helpful to know that there is that accessibility.
Mm-hmm.
So again, thank you to both of you for all of this information and education that I think has been really helpful to, our team at AGI, to our clients and families. We really appreciate you being here. Before everybody goes, those of you who are in attendance today, just want to let you know to please check your email. You'll be getting a survey about the lecture that happened today. Please do give us at AGI your honest, anonymous feedback. So you can be as honest as you need to, because the survey will also give you a chance to give input about other topics that you might want to see covered in our upcoming lectures, and help us develop our online platform for lectures in a way that you see fit. And if you have further questions about anything that we've discussed today, or anything in general about being a caregiver for someone who has dementia, we really encourage you to connect with an AGI counselor by phone or email if you're not connected with one already. And as well, like I said earlier, you will be getting sent a copy of today's slides, so you can refer to those as well. And I want to say thank you to everybody who joined us here today to watch our lecture, and particularly again to Zelda and Patrick for guiding us through this. Thank you.
Thank you. Thank you for being with us.
Thank you both.
Take care.
Okay. Bye, everyone.